Hello, ladies and gentlemen. The title of our project is Clinical K for Electrical Stimulation in Physiotherapy and Rehabilitation. Our project is funded by Erasmus+. The institution that our project is coordinated with is Pamukkale University. Other partner institutions of our project are University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Seoul State University of Applied Science, Burdur Mehmet Akif Ersoy University. Association partners of our project are Turkish Physiotherapy Association, Order of Physiotherapists in Romania, Lithuanian Physiotherapy Association, Estonian Association of Physiotherapy. I will tell you about the topic title Electrophysiological Test, which belong to module 5 with the scope of our project. We prepared this chapter with Nilüfer Çetişli Korkmaz. The diagnosis of neurological disease or nerve damage is made by anamnesis, clinical symptoms, and electrophysiological tests. The definite diagnosis of peripheral neuropathies is made by electrophysiological tests. These tests are frequently used to detect the integrity of the peripheral nerve muscle complex and determine nerve conduction velocity. The purpose of the using electrophysiological test is to determine the amount of motor and sensory nerve fibers and motor fiber conduction velocity of the nerve, thus determining the current function of the nerve. Electrophysiological test methods are examined in the two groups as invasive and non-invasive test methods. There are non-invasive electrophysiological test methods frequently used by physiotherapists in the evaluation of the peripheral neuropathies and the determination of nerve stability characteristics. Non-invasive electrophysiological test methods include methods such as strange duration curve, paradigm test, accommodation ratio, Reobas, chronaxy. Since these methods are non-invasive, they can be tolerated more easily by patients. Non-invasive electrophysiological tests of other advantages are that is more common in clinical, its cost is low, and it allows the motor stability threshold of the peripheral nerve to be obtained. Studies have shown that non-invasive methods provide information about stability of the nerve and provide the opportunity to reliable monitor the nerve healing process. Researchers reported that the combined measurement of non-invasive methods showed 100% sensitivity for the needle electromyography results for the acute phase and complete denervation and 86% sensitivity for subacute phase and partial denervation. There are limited number of studies in the literature investigating the relationship between invasive electrophysiological tests and non-invasive electrophysiological tests. The widespread availability of non-invasive electrophysiological test methods in physiotherapy and rehabilitation clinics to ease the detection of the individuals with peripheral nerve injury, the opportunity to objectively evaluate the extent of degeneration and regeneration in the nerve and denervation and reinnervation occurring in the muscle are among its very important advantages. Therefore, it also allows the planning of the treatment specific to the exciting recovery phase of the patients or the evaluation of the effectiveness of the treatment applied. In this section, electrophysiological evaluation approach will be explained. The evaluation process, neuropraxy is the Mills form of the peripheral nerve injury. This level of injury has a good prognosis, usually without surgical treatment. However, if chronic compression causes progressive dysfunction in myelin producing Schwann cells, the impact has the potential to progress to involve the axon and connective tissue. Axonometry is a second level injury and shows the clinical picture in which the axon is affected, but the connective tissue layers surrounding the nerve are preserved to varying degree. Functional recovery can occur with months without the need for surgery. Regeneration takes place along the endoneurium by axonal regrowth. It takes as long as 14 days to degenerate. The degree of involvement, the third level axonometric injury is higher than its second degree injury. Recovery at this level injury depends on the ability of the axons to extend beyond the lesion site and find the endoneurial tubes. At the fourth degree injury level, the integrity of the axon is impaired except for the epineurium. Scar formation with the nerve prevents the nerve fibers from reconnection. The prognosis is poor. You can see Southern and Sunderland classification. Southern classification have a 3 level. Sunderland classification have 6 grade. You can check anatomical lesion, each impairment. Healing through regeneration cannot occur without surgical intervention in neurometaphyseal type injuries. The important criteria for the prognosis of the degeneration reaction are as follows. Recovery is expected in 6 weeks in the partial degeneration reaction. Recovery is expected in 6 weeks in the complete degeneration reaction. In definite degeneration reaction, recovery is not expected before 1 to 2 years of that is never returned. Fadic type current provides impulse with a duration of 0.1 to 1 millisecond, a frequency of 50 to 100 Hz. The term Fadism was formerly used to denote the type of current produced by the first Faraday coil and is the current that varies chaotically with each cycle consisting of 2 unique phases: low intensity long-term current, high intensity short-term current. This causes tetanic contraction of the innervated muscles, but due to the short duration of the stimuli with Faraday helix, it is difficult or impossible to obtain the response from the innervated muscle. Intermittent direct current is used for pulse of about 100 millisecond duration, which are generally repeated 20 times per minute. These parameters generally cause rapid contraction of innervated muscles fibers while slow contraction of the innervated fibers. If the temperature is below the innervated muscles responds slowly, while the contraction of the innervated muscles become faster as temperature rises. Modified galvanic current is called long duration current starting from at least 1 millisecond up to maximum of 300 or 600 millisecond. Interruption is the most usual variation of direct current. The flow of current starts and stops at regular intervals. The rise and fall density can be abrupt and can be rectangular, south to triangular, and trapezoidal tip. The impulse in which the current gradually rises is often called selective because contraction of the nervated muscles can often be produced with current density that is insufficient to stimulate the motor nerve. If it often happens that the longer the derivative takes, the lower the increases its current density required. Usually an impulse of the 100 millisecond duration is used, which requires a frequency of 30 Hz. However, as the duration increases, the frequency should be reduced to eliminate the danger of chemical burn. reverse current wave, for example, the polarizing pulse that also reduce skin irritation should be used. Degeneration reaction, you can see other model. I will tell about little bit. Partial degeneration reaction, the response to further current decrease in the nerve, more current is required. Response to galvanic current is normal in muscles and nerve. Complete degeneration reaction, response to further current cannot be obtained in the nerve. Response to modified galvanic current is normal in muscles and nerve. Definite degeneration reaction, response to further and galvanic current cannot be taken in the nerve. Faraday extensity test is performed using the Faraday current, which is as an asymmetrical biphasic pulse varying at frequency of 50 Hz. The duration of the Faraday pulse is typically 1 millisecond, which causes contraction at all innervated skeletal muscles. Tetanus doesn't occur because it's applied intermittently 25 times in 60 seconds. This contraction with Faraday current is accepted as a sign of reinnervation after denervation. Lower threshold values are interpreted as a better innervation of muscles. Faraday extensity test should be done firstly for the healthy side than injury side. According to comparison, the Jason were given for the type of extability. Hyperextability degeneration is mean. Hyperextability mean regeneration. Inextability complete degeneration. Wave is equal to smallest 1000 millisecond rectangular wave. Pulse intensity that causes the extability tissue to respond the minimal apparent contraction. Duration of the application also affects the threshold level. As the application time of the current gets shorter, the required threshold stimulus current density increases. Variables is defined as a minimum current intensity required for a very long-lasting stimulus to generate the stimulus. Variables, in the other words, its stimulation intensity required to stimulate a nerve fiber with the longest stimulation time and to reach the threshold level of the stimulus. The normal value of the variables is between 2 and 80 milliampere. Chronax is the duration of the shortest impulse to produce a response with twice the current of the variables. If a constant voltage stimulator is used, the chronaxy of the innervated muscles is significantly less than that of the innervated muscles, with the former less and the latter more than 1 millisecond. Ray and chronaxy refer to measure of stability of nerve axons and fibers with low chronaxy have high stability. Ray-Baz and chronaxy values reach higher values than the normal range in case of injury to the peripheral nerve that is large enough to cause denervation. The mean chronaxy value of completely healthy muscles with innervation is 0.4 millisecond. When denervation occurs in the muscles, the chronaxy values rise above 1 millisecond. Age, temperature, subdermal adipose tissue, skin conductivity, edema, fatigue, regeneration, partial degeneration, and full degeneration status can be given as an example of factors affecting Raynaud's and chronaxy values. It states that stimuli with this for a short pulse duration during application can be tolerated more easily compared to long pulse duration. Electrodiagnostic tests are usually performed with a square wave intermittent galvanic current because the shortest pulse duration and the lowest current intensity can be achieved with a rectangular waveform. Accommodation rate, this accommodation factor is applied to determine the muscle's ability to adapt slowly increasing intensity of the triangular stimulus. To define the accommodation coefficient it is necessary to establish the triangular pulse intensity lasting 1000 milliseconds as well as the accommodation threshold value, which mean the lowest value of the rebus. Normal neuromuscular stability is determined in range of 3 or 6 to 6. A value below 3 indicated decrease until the ability to adapt completely lost. A value above 6 indicates increased adaptability. Strength duration shows relation between magnitude of the stimulus change and duration of the stimulus. Plotting at SDS requires stimulating muscles with a constant pulse duration current ranging from 0.01 to 200 milliseconds at the motor point, and recording the current power at milliampere required to elicit a threshold pivot contraction. It should be done 21 days after the nerve injury. The slope of the SDS gives information about stability of axons and integrity, quality, and quantity of the axon. The curve shift the left when the axon is more stability. This indicated that the same response can be obtained at lower stimulus intensity. In case where the curve shift to the right, it's concluded that the axon can be stimulated more difficult. Galvanic tetanus ratio in square wave galvanic current, it is the ratio of the current intensity at which maximum contraction is achieved to the current intensity at which minimal contraction is achieved. You can see galvanic tetanic ratio. This normal muscles ratio, denervated muscles, and regeneration muscles ratio. Pulliger first discovered that healthy muscles could be stimulated with less current with the cathode rather than the anode. According to Pulliger law, strong currents are required at the physiological anode to generate excitation, and excitation also occurs at the physiological anode. Accordingly, by examining 4 variations, he came to the following conclusion, like this. Polar and apolar stimulation law. The polar stimulation law is valid for direct current and low frequency currents. The polarization and action potential take place under the cathode. Apolar stimulation law is valid for medium frequency currents. The polarization and action potential occur under the both poles. The Boyce-Raymond's law, when the current is applied to nerve suddenly, the nerve can be stimulated approximately 1 volt, while the stimulation threshold of the nerve can reach up to 5 volt when the current is gradually increasing. The rise time of the current should be less than 60 milliseconds in order to avoid accommodation while stimulating the nerve with direct current. Electromyography is used to read myoelectric signals through electrical measurements. MEG, which usually perform together nerve conduction studies, including sensory nerve conduction, motor nerve conduction, and the late response can be quite painful, uncomfortable, and time-consuming. I can see our references. I hope it was a grateful presentation. If you have any questions about the subject, you can send an email. Thank you for attention. Have a nice day.